Great. So thank you very much for having me. It's an honor to be able to come and speak to you all, enjoy this opportunity to learn from you and to present some ideas that we've been working on. This project was done, my partner and I, both students at George Mason University, Volgenau School of Engineering and the data analytics program. My partner just graduated with his master's in July, so congratulations to him. We were interested in estimating the true extent of SARS-CoV-2 spread in the US. And then subsequent to that, we really wanted to see if we could measure using that data an impact of the effectiveness of personal protective measures people are taking in public. So social distancing, not just the fact that staying at home, that when you go into public, that you're actually maintaining a distance from potentially infectious people, and the use of masks and hand hygiene. So states, as we heard about previous talks about this, plenty on the news, states and federal government need to know the actual prevalence of SARS-CoV-2 to take effective measures to stem the spread of the disease and get the pandemic under control. And unfortunately, SARS-CoV-2 infection reporting is not reflective of the actual prevalence of the rate of change of infections in states. I think through this methodology would be an interesting exploration of that, demonstrating further evidence that that's the case. The reasons for why this is are numerous, and we did not get into the specifics regarding that. Okay, sorry, screen, there we go. So our objectives were using CDC data to correct for the number of deaths reported through JHU data, weekly deaths from COVID, to correct those numbers using the CDC data with the excess mortality attributed to other causes, to then generate an estimate of how many infections were necessary in the previous 2 weeks to have resulted in those number of deaths. Then from that, to generate a model to estimate effectiveness of average personal protective measures people take in each state. So particularly interested in mask wear, hand hygiene, and social distancing. The data sets we used for this study were the JHU COVID-19 daily new cases and death data, the Google Community Mobility Report, which has been mentioned previously in other talks, US Census county population and density, the CDC excess death data, and the CDC's total COVID test and test positivity rate. That was an aside that we went into in this to show the relationship in some states. Well, I'll get to that. So, excess deaths attributed to other causes. This is a graphic taken straight from the CDC's website with the report and a dashboard showing deaths in the US per week from 2017 to present, and the number of COVID cases, and still that doesn't explain the excess number of, so the green bars represent all deaths that per week that are not COVID related, not COVID coded, and that we see in excess over the predicted numbers for the states. This is all the US, and the dashboard's really nice, nice dashboard. You can drill into individual states. This is taken from the same website, a graphic demonstrating what excess deaths that they are attributed, that they have calculated that have been, quote unquote, my words for this, misattributed to other causes. So this actually represents about 75,000 excess deaths since the start of the pandemic in the US attributed to other causes that are likely COVID related, actually. So I think yesterday I checked the numbers, and it's about 162,000 COVID related deaths that have been reported to date. So this is almost 50% excess, 50% more deaths that are likely caused by COVID, but it's in the range of 225, 230,000 deaths to date. So for our study, we were using a very simple formula for making the corrections to the deaths, taking the weekly sum of the JHU daily deaths, and then for data that's more than 4 weeks old, we actually used the week's reportings from the CDC for excess deaths, the numbers that they have calculated, and multiply that, or excuse me, add that to the value to get the corrected deaths. Those are our words that occurred that week that were likely caused by COVID. But the data in recent weeks, we were not using the week's reported data because there's a bureaucratic delay in reporting the information to the CDC's National Center for Health Statistics. It takes a number of weeks for that information to catch up. So recent week data is not reliable. What we did to correct for this was instead take the average of the previous 4 weeks and use that value for the recent data. However, in the process of writing the slide deck, I discovered that the CDC has stopped updating this data, and the latest data we have is from August 8th. So we won't be able to use that methodology going forward unless we can find an appropriate substitute for it. I don't know why that is. That occurred after was July 15th, that there was a change from reporting statistics regarding COVID cases and deaths from CDC to HHS. I don't know if that's related or not. So there's actually, I need to go back and change the calculations in our Python module for this, or excuse me, our notebook. You can see in lines 265 and 266, that's when the reporting from the CDC ran out. And so we are not using an appropriate multiplier for those 2 weeks. But you can see in lines 267 and 268 that the new deaths reported through JHU, 483, 423 for those 2 weeks, and we still use the average of the previous 4 weeks. So actually the last 2 weeks are probably a little bit low based upon the trends we saw. For example, in this case, it's Georgia. So the result of that in the far right column is what we call our corrected new deaths, 538 for the week of 8/15 and 478 for the week of August 22nd. From that, to calculate the number of infections that needed to have occurred in the past to result in that number of deaths, we use the infection fatality rate, not the case fatality rate. So the IFR is the proportion of people who get infected with the disease causing agent that die from that disease. Vice the CFR is the proportion of people who are identified as being affected that die from that disease. The CFR is skewed by a number of factors, one of those primarily being the limitations of testing in the US. So by searching literature, the estimates appear to be converging around 0.0065, an IFR of 0.0065, so 6.5 people out of every 1,000 people that get infected ultimately die, succumb from the disease. And that the median time from infection to death is estimated at 14 days, with a very wide range, though. Next slide. So using that information to estimate the infections, we're estimating the infections that occurred 2 weeks prior to have resulted in that many deaths. So we start the left-hand side on the bottom. The new deaths reported in JHU is 161. And so that's, for example, this example, we're looking at Indiana in May. So on 5/30, there were 161 COVID-related deaths reported. And then using the corrected new deaths from the CDC excess death data, we calculate that to be 168 deaths actually occurred that week from COVID. Doing the multiplication, going back in time 2 weeks, that meant that 24,705 people were likely infected at that point to have resulted in that many deaths. And this is very simplistic, and I can fully appreciate that because we're not accounting for demographics, and that's meaningful. We just have a lack of data to be able to get after that. But you can see in comparison, the estimated infections vice those reported in the JHU data for that same week. Indiana reported 3,500 estimated infections, and yet there were 24,000 by our calculation. There's also a discrepancy in time with this, though, because there should be a phasing issue. I would expect that most cases that are reported through the JHU are probably occurring about a week after the actual infection occurred. You're not going to turn positive on the day that you got infected. It will be a couple, 2, 3, 4, 5 days before you'll turn positive, depending on the test methodology that's being used. So even if you're assuming that it's shifted by a week, the trend in Indiana at this time, I should have shown the previous line 351 from this, is roughly the same. So it's about 7 times more people infected that we're estimating by our method than are actually being reported. This is data from Virginia for the course of the pandemic to date. As I said, our data back projects 2 weeks ago. So the data that we've calculated in the orange lines, which is estimated infections, goes up to August 8th. Vice the actual data from JHU, we are summing by week up to August 22nd in this case. That you can see that there are significantly more cases by this estimation method, and also that the cycles that are going on with the new cases that are reported to JHU versus what's calculated are significantly different. And that's the trend in almost all the cases. We have further data, if people are interested, could share with you to show the correlations are not good within states, in most states. One thing we did was that we took the data then and summed up the total number of estimated infections that have occurred in each state since the beginning of the pandemic, and divided that by the population of the state to get an estimation of the proportion of people that have been infected to date within the state. So this is based upon deaths. And reinfections, if they are substantial and occurring, this doesn't account for those. So it would be, I don't think this would change actually though, the number that we're estimating. So the reported New Jersey is the state with the highest to-date infection rate by our methodology. The reported proportion of people in the state that have been infected is on the order of 2%, whereas our method is estimating that it's almost 33% of the state to date have been infected. And New York and Connecticut and Massachusetts and Louisiana, not surprising, these were states that were hit early on in the pandemic. Overall, for the US, we estimate that 10.5% of the population as of August 8th have been infected versus a reported total of about 1.5%. Once again, about 7%, sevenfold more. So this slide I'm showing, we'll take a quick excursion and show, you may have heard talked about the use of test positive rates as a surrogate for measuring actually is the disease increasing or decreasing. And in some states, it actually correlates really well with our estimates. And in other states, it correlates not at all, or even negatively. So this might be a methodology to actually understand those states this is a useful tool for versus those states that there are other issues driving the test positivity there, skewing it so that it's not useful for determining what's going on in that state. New Jersey is the state with the best correlation. It sits right on top of it. I would not expect that. I would expect it to actually be skewed forward a week. In other words, because testing occurs after the point of infection, you would expect the positivity rate to lag by about a week. You do see that in the New York data. In the New Jersey data, it sits right on top of it. So New Jersey is the best correlation, whereas Arizona is about the 10th best. And you can see that early on in the infection, the correlations weren't very strong visually by visual inspection of the graph, but subsequently it gets better. So it might be a good estimate within Arizona. Although in this latter bit of the data, I suspect that's probably a bureaucratic process that's causing such a dramatic decrease. I don't know though. That would be interesting to pull the thread on or to see what happens going forward in time. These two represent the 40th state and the 50th state. So Georgia is the 40th, in this case, worst, and Kentucky is the worst of the correlations. And so actually, Kentucky, if you were to throw out the first portion of March, the data in March, if you were to draw a line through the blue line, the estimated infections, it tracks kind of with the test positivity rate, sort of. But in Georgia, you see a clear example that there doesn't seem to be a good correlation at all. So in this case, if you're reporting the spread of COVID within Georgia based on test positivity rate, I would have significant skepticism in the value of that analysis. So given that what we had done, we were then interested in moving on to assessing the value of personal protective measures on the spread of the disease. And I would like to say, I think with this audience, it's not necessary, but to talk about the fact that non-pharmaceutical interventions have a long history in the control of disease and have been the primary mechanism by which the humans in general have gotten significant control of infectious disease, driven the rates down tremendously. This is from a report. This graph is from a report from the CDC in 2000 about the century of progress in disease control achievements in public health. In the 20th century, and at the beginning of the century, there were 800 deaths per 100,000 people per year. And that rate dropped basically tenfold by the middle of the century. The vast majority.
This is your 5-minute warning.
Okay, thank you. The vast majority of that occurred because of non-pharmaceutical inventions, pasteurization, water treatment, sewage treatment. Now, these are for diseases that are waterborne and foodborne primarily, not so much a respiratory infectious disease, which are a different transmission mechanism. But this slide is to indicate we have reason to believe the value of these approaches for SARS-CoV-2, in that the initial estimates of SARS-CoV-2 for its infectiousness in the early, this is reporting from back in March. And then as we've gone through, the reporting has tightened up that the infectiousness is somewhere between 2 and 6 individuals per infected individual. So this is an R0 estimate. That it is not an extreme outlier. It is not measles. It is not whooping cough. Non-pharmaceutical interventions have the possibility of controlling the outbreak. So I would like to say in this, one of the key points is that social factors play a significant role in the infectiousness, and I'm really trying to get to that non-pharmaceutical interventions and social distancing can have a tremendous impact. So for respiratory disease chain of transmission, you have from an infectious person to a susceptible person, and the transmission mechanisms are aerosols or particles or fomites or direct contact. You can't rule out kissing in these kind of diseases. I don't think that's a substantial contributor to this, though. So there's quite a bit of debate about whether or not SARS-CoV-2 is spread through aerosols or particles, and the CDC has come out thinking that fomites are not actually a major contributor to this. Both of these, there are ways, engineering controls that can be brought to bear. So we want to measure the effectiveness of what's currently going on. Because I'm running out of time, I'll get into that. I think this is common knowledge now from reporting in the news, but the wear of face masks, the wear of glasses or goggles, practicing good hygiene, being mindful not to touch your face after touching potentially contaminated objects, and frequent hand washing and social distancing to avoid close contact with potentially infectious individuals is very important in controlling the spread of the disease. For our assessment, we took a rather simplistic formula to calculation that we were trying to get to, which is measuring, we wanted to get to measuring the behavior change, the effectiveness of behavior changes. I'm referring to it here. So the daily infections are dependent upon the average daily encounters per individual, state population, the probability an encounter is infectious, behavior change effectiveness, and transmission effectiveness. Because I'm out of time, I won't go into detail about that, but that by rearranging this, we have a method for developing a metric to estimate, are these effects reasonable? This is dependent on, there are really two variables that are meaningful for our calculation though within this, which is the weekly infections and the weekly encounter rate, which we use Google mobility data for. This is a thought experiment, and so it is full of assumptions on this, and there is more work to do to elucidate this, largely because there's insufficient data to really go out and measure the reality. So I would just like to caveat that this is just a thought experiment, that we are not proving, we have not proven that this methodology works. So the Google mobility data is broken up into 6 different bins. As you've heard about, retail, recreation, grocery and pharmacy, parks, transit stations, workplace, and residential. When you plot the data out, here's an example from mobility changes in South Carolina from the beginning of the outbreak into May. You can see significant changes, but how is this useful? We want to develop an index from that. So one of the major assumptions we made is that there are encounter rates associated with each category. This is different from an exposure. It's a term that we came up with in the process of writing this, developing our model. An encounter is how many times do you come into approximate contact with somebody in a different activity bin per hour. So if you go to the grocery store, you have potential contact, potential exposure events at a much higher rate than you do at home when there's nobody coming to your house. And so we made significant assumptions to go forward with our model on this, that number one, Google reports a percentage change in activity, and we went back and did an estimate how much time and energy. Go ahead.
You have 1 minute left, so go ahead and provide.
So I'm going to have to go ahead and sum up what we got to with this, accounting for population density, which in the course of our work we discovered is a tremendous driver in this, which other previous work has demonstrated also, is that this is representative of the weekly exposures for New York versus Wyoming, New York being the highest density state and Wyoming being the lowest density state, and that the calculated exposures that occur per week, encounters that occur per week based on the Google data are significantly higher for Wyoming than New York when you don't correct for population density, but that relationship tremendously reverses when you do count for population density. We did get to I'm going to skip past the slides and apologize for that. I would say that the issues that we encountered in this study are that the baseline encounter estimate rates that we estimated are wrong and way wrong. We need better data to figure this out. Social behavior across different states and regions probably changes the baseline encounter rates. Once again, data to help us figure out what these encounter rates are would be very useful, and we're continuing to work on that. And that state level granularity does not represent the reality of infection drivers, and it would be better to do this at the county level. I would say that in July, go ahead. Thank you very much. Appreciate your time.
That's all the time we have, but thank you. This is extremely interesting.